Good evening. Welcome. My name is Rick Page. I'm Dean of the Larner College of Medicine and Chief Medical Affairs Officer at the University of Vermont. But most importantly, I'm the person who gets to welcome you to the 2026 Reverend Dr. Martin Luther King Jr. Health Equity Lecture. We're so glad you're here. I just heard there scads more people listening in on Zoom. So I'm looking forward to approaching 100 people on Zoom. We're approaching 100 people here, and I'm really delighted you all have turned out. This topic has never been more timely. It's amazing to think back. This talk was established more than a decade ago, inspired by one of Dr. Martin Luther King's most powerful statements that he made in 1966 at a press conference before the annual meeting of the Medical Committee for Human Rights in Chicago, words that resonate today just as they did then. And I'll quote, "Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death." And that's what we're up against. Since 2014, this event has united our community in honoring Dr. King's call for health justice, sparking dialogue and action for meaningful change. Over the years, we've explored critical issues from the Flint water crisis to how a person's zip code can predict health outcomes. Each year, this lecture brings together distinguished individuals from medicine, public health, ethics, and the humanities to examine the root cause of health disparities, explore the historical and social context, and share innovative solutions that advance excellence in healthcare. Normally, Dean Margaret Tando, Associate Dean for Intercultural Excellence, would be here. She's on a beach somewhere. Maybe, Margaret, if you're in Maui or wherever, we're thinking of you. Thanks for giving me the opportunity to do all the talking before our speaker today. I want to thank Tiffany Delaney and the entire Office of Intercultural Excellence for their continuing efforts to educate and inspire our community on issues that profoundly impact medicine and healthcare. And I just point out the work, the core values are the same. The name's a little bit different than it was last year or maybe the year before, but let's give them a round of applause. We're still at it. So tonight's topic is both timely and urgent. In an era marked by politicization of health, widespread malinformation, and lingering skepticism following the pandemic, trust in medicine is under strain. Addressing the challenges that we're facing is essential to safeguarding equitable access to care and restoring confidence in our health systems. Now, before we start tonight's talk and I introduce our speaker, I have a couple housekeeping notes for you. Tonight's lecture is also CMIE accredited. You can scan those QR codes up there and provide access to session evaluation and to claim credit. These will be added to the online chat as well for those who are online in the audience. There will be opportunity to ask questions for those online as well. I would note that this is our CMIE slide. I should leave it up for a little bit longer than that. There are no financial relationships that need to be disclosed related to tonight's talk. So now it's my privilege to introduce our speaker, one of our own, Dr. Tim Lahey, who will lead us through a thought-provoking lecture or talk on, we don't do lectures at Larner. This is an education experience, no lecture zone. He's going to provide a thought-provoking session where we address a very timely issue, and that's the growing distrust in medicine and its implications for the future of healthcare. Dr. Lahey brings a medical ethics perspective that will help us explore not only the roots of this distrust, but also pathways to rebuild trust and strengthen the patient-provider relationship. Dr. Lahey is an infectious disease specialist, director of ethics at the University of Vermont Medical Center, and professor of medicine at the Larner College of Medicine. He's written extensively on ethics, HIV and tuberculosis immunology, and infectious disease epidemiology. Beyond academic writing, Dr. Lahey has contributed to popular outlets, extending the reach to organizations such as the New York Times, the Washington Post, the Atlantic, on topics of compassionate care. He serves as treasurer of the National Board of the Albert Schweitzer Fellowship, is a member of the Healthcare Ethics Consultant Certification Commission, and has been a longstanding contributor to the National Board of Medical Examiner Foundational Science Committees. An award-winning educator, Dr. Lahey was named Vermont Physician of the Year in 2022, following his widely recognized and important public communications during the COVID-19 pandemic. During those dark days, I can say from personal experience in listening to him on many occasions, he was a clear and wise voice, bringing together his expertise in infectious diseases, his insight into medical ethics, and a long-term commitment to social justice. With that, please join me in welcoming Dr. Tim Lahey.
Thank you. Well, it's all downhill from here. Thank you very much, Dean Page, for the welcome. Thank you to Tiffany Delaney and in absentia, Dr. Tando, and to Olive Gallmeyer and the whole team for making this possible. I really appreciate the opportunity to be tortured in this fashion. So we're going to talk about Code Blue, resuscitating trust in healthcare, and I hope by the end to give you some specific, tangible, pragmatic responses, and also to explain why I think my choice of a title is overblown. This is the quote that Dean Page highlighted that entitles this lecture series, and I was reflecting on how it is that health inequity, one of the worst forms of inequality, relates to the topic of restoring trust in healthcare, and what are the connections that we should be drawing out here. And en route, I want to surface the question of why I should be standing in front of you with my background and looking like this. So to try to approach that, the road I'll try to take you to is first to think about the connections between restoring trust in equity. I want to talk about the nature of mistrust and the variable nature of mistrust and some of the drivers in it, and then to try to spend most of the time talking about what can we do about it instead of feeling like the sky is falling and alienated from this work that we love, instead feeling empowered to make a difference. So first, equity. If you think about what informs health equity, there are multiple axes that in order to achieve health equity, people have to have a safe environment to live in. People need access to preventive measures. If they need help, they need to be able to access it. While accessing that help, they need to be treated with dignity and respect. And of course, they expect the best care possible. I think you'll agree that all of these axes actually relate to trust in one direction or another. That, if I do not have access to safe drinking water, if I am exposed to toxic waste in some inequitable fashion, my trust is undermined. If I don't trust you, I will not come in to get a vaccine, or I will not believe you when I say that I need to wear my seatbelt. If I can't access care as easily as my neighbor does, I will notice it and I will judge you for making that impossible. And then I think probably most profoundly, if when we are face to face and the exam room door closes, if you do not treat me with trust, if we cannot bridge, if you do not treat me with respect, if we cannot bridge that, whatever differences there are between us, my trust will be undermined, and so on. And so I sort of think of all of the axes of health equity as really intimately involving trust, either as an output of health equity or health inequities, or actually as the mechanism that we use to achieve it. So I think this is a critically important and I think neglected topic in health equity. And of course, this year is a great year to be talking about social trust and trust in health. My predecessors in this lecture series, including the inaugural lecture, Dr. Adewale Troutman, knew this well. And so he said that we should get people on the same page, become an ambassador for health equity and social justice. That this is part of the work of health equity, is to get out there and get the word out. Dr. Mona Hanna, formerly Mona Hanna Atisha, 3 years later said this. She said, "Flint is your struggle. You will not look back on your life. You are not going to tell yourself, I wish I had stayed silent." Professor Dorothy Roberts, 1 year later, called our attention not just to the obligation to do something about this, but to our history of contributing to inequity. She gave examples of physician perpetuation of racism. One word that she highlighted was drapetomania. This is a medical diagnosis that we use to legitimize racism. This is the apparently psychologically abnormal desire to escape captivity. So what is the nature of the mistrust that is out there that we have an obligation to improve and that we have contributed to? To talk about mistrust, I should tell you about my wife. So this 1,000-watt smile, I knew it was coming and I started choking up already. So this 1,000-watt smile of a writer, a public speaker, and unrepentantly dirty gardener who, when she comes back inside at the end of a summer day, looks like she has used her head as the gardening tool. Dog lover, mother of 2 beautiful children, and mother of these 2 books. And 3 months ago, a cancer patient. And since this time, we have learned about trust, particularly 6 weeks and 5 days ago. I knew I was going to crack up on this. I knew I was. Since 6 weeks and 5 days ago, when I kissed her on the forehead and told her I loved her, and she wheeled away into an operating room, and I had to trust that she would be okay. These were caregivers who we had just barely met, and we had to just throw her life and our future fate into their hands. And it raises a huge question, which is, why did we trust them? And I'm curious what you think. As you roll into the operating room on a stretcher as a patient newly diagnosed with breast cancer, or her tearful husband, why do you trust those caregivers? What do you think? They're competent, Karen. Thank you.
A lack of other options?
You have to. Which, I mean, I researched these people and I wanted to know if they were any good. And also, part of me is going to set that down at a certain point and just trust that they know what they're doing. What else? Beyond their CV and desperation. A friend recommended them, word of mouth, a trusted sage advisor. What else? What makes you trust people? Yeah.
That they are working for trust.
Yeah. How? How do you earn trust? We had known these people for a week or 2.
Listening, empathy.
Yeah. It's so much happens in those few seconds as they look you in the eye and you get a sense of who this person is. I could go on. There are a number of inputs in this, but I think you'll agree that when we say trust, we don't mean just one thing. We mean this mixture of they have great credentials and they looked me in the eye and they actually listened and dang it, they just better be good because I love her. When we talk about trust in healthcare, I think we should talk about that not only is it that complicated mix, but it's also a mix of trust in one-on-one care, trust in public health messagings, get your vaccine this year, boil your water, whatever it is. And also trust in the kind of often hidden systems that are underneath. Will I be able to get an appointment? Are they actually checking the water to see if there's E. coli in it? That stuff that we're just sort of dimly aware of. And what we're talking about is at the intersection here, the big healthcare that influences this. And I think it's not just these particulars to make it more complicated, that trust in the entity of healthcare is profoundly influenced by social trust in general, and I think no more true than 2026. And to get into that space, I have a graph here of the percentage of Americans who say they trust the government in Washington is going to do just about what is right for them, or all the time, or most of the time. And you can see that in the administrations of Eisenhower, Kennedy, and Johnson, about 80% of people would answer yes. But in the decades since, we've had a decline. You can kind of squint into this to see Watergate and Oliver North and the Iraq War and the last 15 years of political strife. You can also see some interesting patterns in here. The administration of the party of the president affects who feels most trusting in government. But also you can see that in the last 15 years, things have not recovered since the drops after W. It's not just government. It turns out that this is symptomatic of a larger decline in trust in public institutions. So here are a number of different sorts of public institutions. In dark gray, they've broken down the change in public trust from the 70s to the 2010s in the Congress, the least trusted body of government, the executive branch, or the Supreme Court. And clearly there are different levels of loss of trust, but all of them have lost trust. In fact, the military is the only group that consistently has increased trust in those decades. And here we are, medicine in the middle, a 20-point drop in trust since the 1970s. And this trend continued into the pandemic era. This is a slide from the M.M.Sc, sort of merging some different national polls suggesting that hospitals lost 5% trust, pharmacists lost similar degrees of trust. So this is a continuing trend that affects healthcare in many public institutions. I want to make a distinction between trust that you might have in a larger government to trust that you might have in sort of a certain subset of civic institutions to specific professions. And it turns out that the picture of loss of trust is still there, but it's a different picture. So on the left, you can see that the most trusted professions in our society are school teachers and nurses. And they really haven't had a huge drop in levels of trust to them over the last few years. On the other hand, while doctors and pharmacists and military officers are still among the more trusted people in our society, there have been dips, particularly in trust of physicians, but not to the level seen to lawyers, business executives, or members of Congress. So we're sort of picking and choosing where we place our trust, which basket we put our eggs in. This is palpable. So this is an article from an infectious diseases colleague of mine in Dallas. And she talks about how I can feel it before I even speak. With approximately half of my patients, when I bring up vaccines, attention settles in the room. I see the stiffening of posture, the guarded expression, the subtle shift that says, I've already made up my mind. Sometimes patients shut down immediately. Other times they start asking me a barrage of questions fueled by the misinformation they have been exposed to. This is not a disagreement grounded in evidence. It is not a conversation between two people weighing risks and benefits. It is a wall, thick, immovable, and rapidly rising. I know what this feels like. Recently, I had a patient whose life I helped save, hospitalized in this hospital with a serious bloodstream infection. We were on our last visit when antibiotics had stopped and she was doing well, and we had really kind of a nice joking rapport. And I was like, before you go, I should let you know about this COVID vaccine. The new one's just out and good data suggesting it can protect you from hospitalization. And I'm realizing anger is coming at me, and she did not want to even have this conversation with me. So I pivoted and we talked about other ways to protect her health, but I think we've all been there. I don't want to say that my experience is that 50% of people put this wall up. I don't actually have that high of a prevalence of resistance to this. Maybe it's because she works in Texas and I work in more pro-vaccine Vermont. So I would say that our experience of this is various depending on our profession, depending on our geography, et cetera. And I think that variable experience of trust, that variable exhibition of trust is something that's really important to look at. I think the most potent data in regards to this relates to this Pew study of 4,736 Black adults in 2024. They showed that more than 75% of Black adults had experienced discrimination at some point, 13% regularly. And if you sort of and when they assess in various social institutions, not surprisingly, those who had experienced discrimination had lower levels of distrust. If you've been mistreated, you of course are not gonna feel as trusting. 47% did agree that healthcare has improved, but still 55% reported negative experience with MDs, and 51% answered yes to the question of whether healthcare is holding them back in some way, perpetuating that major health inequity that Reverend Dr. Martin Luther King Jr. pointed to. Society, there are levels of trust toward them. There are institutions that have levels of trust. There are professions. And I want to highlight this data too, which I think is really important. If you ask, as the Kaiser Family Foundation did, Americans, how much do you trust each of the following to make the right recommendation when it comes to your health? 85% of people said, I trust my doctor. And this survey did not include questions about your nurse or your other known healthcare provider. But I think this speaks to a difference between doctors in general and my doctor. If you know that person, if they have looked you in the eye and sort of treated you with respect, you have built some trust. So I think it's important to differentiate between these two, that you don't maybe get a free pass walking in the room with a white coat on or a stethoscope around your neck, but you can earn trust. And when they asked about other sort of aspects of the health system in the United States, from the NIH to the CDC to specific individuals like RFK Jr., Mehmet Oz, and President Donald Trump, you can see that there are wide degrees of trust or mistrust in these individuals, I think hugely influenced by people's experience of these entities. So trust varies by proximity and experience. Okay, so far I've said that trust is complicated, that it has this very complicated social context. How you feel it probably varies from person to person, from relationship to relationship. Proximity, the social vibe, what decade it is, makes a huge difference. And maybe that's a good place to get into drivers. What is influencing us? And I think really the question is not why is trust in healthcare on life support, because I don't actually believe that we should say that it's on life support if 85% of people trust their doctor. But it is injured and it is in danger and it's worsening. And so I'd say this is a call to action. So why? I think it breaks loosely into geohistorical context and anti-communal behavior. So for geohistorical context, human nature, this is my body. I did not just automatically trust anyone as my wife wheeled into the operating room. Of course, we're gonna check it twice and feel natural mistrust. And so I think we should have realistic expectations about that healthy human behavior of mistrust. In a society that fetishizes rugged individualism and individual autonomy, I think it makes sense that we might be a little bit less, on average, trusting toward an institution like healthcare than if we were a much more communal society that sort of expected trust and maybe had the social dynamics that earn trust in that space. So I think that's part of the American experience, and perhaps trust in institutions is something that is risky and so shouldn't always be there. I think an important contributor to this space that I think is familiar to this equity-interested audience is that American demographics are changing and the power structure in the United States is changing for good, and that's probably affecting this readout. So imagine back in the 70s, if I, a white man, the people who are asked their opinion, are asked to opine about my opinion of this probably white man who's providing care in me, and that white man is a member of the father knows best, Dr. Welby generation of doctors, it seems likely that I would say, yeah, he's a good guy, kind of like me, I get him, trustworthy. Complicate that. Imagine if you have a much more diverse healthcare workforce, and therefore the likelihood that those people in the examination room are communicating across some form of difference, some demographic difference, there may be not automatic trust across that difference. And so some of it may just be that we are, for good, diversifying the workforce, and so we're having a need to just communicate across difference. Well, what if I also diversify rightly the people whose opinion I'm asking? And I ask not just the white dude who's got good access to that other white dude, but I ask people who have been historically marginalized from healthcare and historically not asked their opinion. They're probably going to tell you what they think, which is not great. So now we see the mistrust that was probably there, but just not recognized. I also think that one change that has happened in the last 20 years is that public dialogue and critique about these systems has become part of our work, that just kind of automatic acceptance of authority is not there, and that we rightly expect high performance and we name it when it is not there. So partly I see the decline in trust as more of evidence of a healthy dialogue. Yet, I do think we have to think about medicine's mistakes, among other misbehaviors, as a huge driver. Could it be that when I was in my white coat as that empowered member of our society, possessing of expertise, expecting trust from people, that I just sort of said, take my advice and just listen to it and don't ask too many obnoxious questions? I think we all know that this can happen between patients and physicians, between patients and healthcare workers. And can that have undermined trust? Absolutely, it could have. Could it be that cash grabs have been part of it? There's an ample literature looking at physician behavior being affected by the likelihood of getting a bonus at the end of the year if you do that number of procedures, or if you do that procedure that maybe doesn't have great backing for it. We now have how do you say, like a runaway documentation system that is meant to prevent fraud from physicians. And I'd say it's probably more wasteful than the fraud from physicians, but it is symptomatic of fraud. And people are noticing that. And so I think our attraction to money is something that we have to own and think about as a contributor. Information and misinformation have been on steroids in recent decades. It turns out that Dr. Google wasn't a thing 30 years ago, but now our patients come in with great questions and great information from the internet, and maybe they realize when I don't know the answer to that thing. I had a powerful experience on the radio once during the pandemic talking about the safety of COVID vaccines, and I said, there are a dozen reports of myocarditis in young men after giving an mRNA vaccine, something that really bears close watching, but not something that makes me, cool my enthusiasm for these life-saving vaccines. And a caller called in and said, the American Heart Association has 250 cases of myocarditis. Why are you lying to us? Well, I didn't know that they had updated their web pages in the last week, and so I got to a commercial break, checked it out, and had to get back on the radio and say, the caller is right. Here's the data that I see on the AHA webpage. So we can get caught like that with the internet today. That changes trust. But of course, misinformation is easily available too, and that can lead people to believe that they are not getting good care from us, even if they are. The politicization of health. This is not new. Health is political. And yet also, I think we have seen major political actors use, whether it's vaccines or nutritional advice or various other cockamamie theories, to gain political favor and exercise power in our country. And I think that's confusing. They're just kind of hearing people yelling at each other about health-related things, and it probably doesn't instill trust. We've seen Senator Rand Paul yelling at former head of the NIAID, Tony Fauci, about how he's to blame for all the bad things in the pandemic. And I don't think that was good for either of those individuals. It did not instill trust in the American populace. And I think that's one example of many recent events. There's COVID, there's the incredibly inflamed and polarized dialogue in the political sphere. There's RFK making, I would say, incredibly damaging changes to our public health infrastructure. I don't know if it relates to his brain worm or not. And I think most recently having masked thugs abduct and murder people has been bad for public trust. And I can't prove that in a randomized clinical trial, but I think you'll agree that it is true. So it is complicated in its manifestations, this trust we're talking about. It has very complicated origins, and yet here we are wanting it to not be thus and hoping to make a difference. And I don't want to pretend that it's an easy one, signal answer, but I do want to put to you that we've got this, that we do complexity every day. That if you have a kid, I'm going to stop mentioning you in talks. If you have a cancer and you are afraid, you will get good care when you roll into that operating room, and you will be treated with respect. If you have an unusual bleeding disorder or a difficult to treat infection, or you're having a psychotic break, you, generally speaking, will come in and you will be treated with respect. Are there exceptions? Yes, absolutely, there are exceptions to that. But generally speaking, this building is full of people who get up in the morning to do good. So what does that resuscitation look like? What would be great is if we had an algorithm like this ACLS algorithm. So on the left, if you have pulseless ventricular tachycardia or ventricular fibrillation, everybody carrying the code pager in the building knows exactly what the steps are. And if you exhibit those in one of our hospital rooms or in our ED, they will run this algorithm over and over again until you survive if you can. If you have pulseless electrical activity or asystole, it's a little bit of a different algorithm, but they're going to run that algorithm. I don't know of such an algorithm for trust, but I think we need to think about what our epinephrine is and what our defibrillation looks like. I think first, this really compelling article from Dhruv Kalar, and a former New York Times writer and hospitalist, writing in December in The New Yorker, speaks really importantly to the key thing we have to know is that the code call has sounded, that we do need an algorithm, that I actually don't think that it's urgent, like trust is going to collapse tomorrow, but I do think that there's a major threat to trust in healthcare and we need to respond with an algorithm. Dr. Kular said that some patients don't trust us, others say they don't need us. It's time for us to think of ourselves not as high priests of healthcare, but as what we have always been, healers. He says, doctors can remake their profession by embracing the multipolar medical landscape they now inhabit and by acting as a kind of system stabilizer, working with other powers to help shape rules, norms, and relationships. A superpower may act as though it can stand alone, but middle powers know the value of diplomacy and coalition building. Doctor knows best is dead. This is who we are now. If we act as if doctor knows best, we're lost. And along those lines, I do think that a natural reaction here, if you've been the top of your class over and over again, and you have worked hard and you've taken call and you have self-sacrificed to get to where you are, trying just to help people suffer less and live longer, and you were met with mistrust and misinformation, I do think a natural response is to feel underappreciated and then to say, no, I am the expert, and to talk louder. And maybe we could sort of say, oh, kids today, they're just accessing the internet so much. Back when I was a tyke, I learned so much more effectively. Or how come people are so mistrusting? I just have such good intentions here. It could all add to disengagement and talk to the hand. I don't think that's going to help. I think we need a different algorithm from that. And so I'll tell you about some of the pieces of the algorithm that I would have, and I'm hoping we have some time to sort of hear how you would add to that, change that at the end, because I think one part of standing up here is this is a huge topic, and I do not have all the answers, but hopefully this is an ongoing dialogue that we have. I think the algorithm loosely comes down to doing what makes us best better, and thinking about what our core value is to our patients, and thinking about in this time of change how to double down on that while not being stodgy about the stuff that we have to abandon. So I'll tell you what I mean. And by the way, if you wanted to just subtract restoring trust and put AI in there, I think that would all be true. But we'll call it healing. We're healing trust, because maybe it's not so acutely sick today. So listen with curiosity. I'll explain what I mean by that. Put patients first at an individual and system level. Speak up, but avoid intemperate speech. And I'll tell you what I mean by that. Share facts, uncertainty, importantly, and stories. Belong to the community and talk the talk as well as walk the walk. So what do I mean by those things? First, a caveat. There are no major randomized clinical trials. There's not the asshole group of doctors randomized to the really nice group of doctors and multiple endpoints at the end. That's hopefully not going to happen. I've been happy to see that the Guinea-Bissau trial of hepatitis vaccine that would randomize babies to a placebo for a proven vaccine has been put on hold. And I think similarly, it would be unethical and Tuskegee to do the asshole, no asshole condition. Much as all of us may experience this as the asshole or otherwise. But there are surveys, there are focus groups, there are cohort studies using follow-up of the people on the surveys to get a sense of what are clinician and patient traits that predict trust. And so here are some of the clinician traits. They loosely break down into fixed traits and communication patterns, demographic traits, for instance. But I think you'll see as I show you the examples that there's some mixture between these two. Some of these fixed traits might actually just be communication patterns. So female clinicians are more trusted in a few surveys. Perceived competency, including just having more experience, is a marker of patient trust. Having a good reputation from peers, the recommendation that my wife talked about, is a marker of trust. And the patient having the ability to choose the person who they thought was best, whatever it was that they thought would be trustworthy to them was really important to doing it. Now, you as an individual clinician may not be able to affect that, whether they had choice to pick you or not, or what your gender is or whatever. But I think it's good to know that this might be influencing decisions before they ever enter the exam room. But very powerfully, recurrent patterns in these two analyses of a wide literature show that compassionate communications, clear communications, taking the time to explain what's going on, giving patients options and asking them which one they want first, talking about, hey, I called the specialist and what she said was this, and so what we're going to do next is do this. Does that make sense? Do you have questions? Kind of connecting the dots and helping people understand how they're navigating through the system instills trust. And for good or for bad, how we look and smell affects how people think of us. I think it's probably changing what it is about how we look and smell that or probably just look instills trust. That what is expected of a doctor's appearance is changing since the 70s, but sort of not alienating people with inflammatory political slogan or something like that, I think is good to think about, and how to dress like you, but dress in a way that people will not feel alienated by. So what were the lower trust associations? No fixed traits other than these were associated with trust, but poor explanations, giving information in an insensitive manner, being disengaged in the conversation, appearing to lack concern, making mistakes, and just not being available. And when I hear this, I think you'll probably hear some of the stuff that might be under it, like, is there a status difference between the patient and that person's the doctor's sort of acting like, you've come to me as the expert and I'll tell you the answer? Could they be just trying to control the conversation because they're busy, or they're trying to have control over their lives and then communicating in this way because they're in a hurry, for example? Could they be communicating across difference and not really navigating that super skillfully, that it would be helpful to build more bridges and ask more questions and earn the trust, but they're sort of like, no, I'm just going to zip through because this is my shtick? Could they be exhibiting bias? And that's the part of it. And might some of these things be wound into each other? Difference, of course, being a platform for bias. So one, listen, I think it's incredibly important. There are many, many studies suggesting that patients profoundly desire to be heard by their clinicians, and that it does influence trust. And yet clinicians have many reasons why they may not exhibit excellent listening. They may already know what the diagnosis is. They may be in a hurry. They may be distracted by whatever. They may be sleep deprived. But paying special attention to sitting on your hands and closing your mouth and just listening to the patient is incredibly important. And I would say that in my busy days, whenever I'm feeling impatient listening to a patient, I try to remind myself that it will save me time later to listen to this person now, because generally speaking, patients will tell you what's important to them and they will give you hints about what's going on if you listen carefully. And even if they were not, the trust that you build listening to them while sitting on hands if you have to really does help you get their buy-in later when you recommend a treatment or if you ask them indelicate questions or whatever it is. So just investing and investing again in listening is so important. I think of this as part of putting patients first, like centering them in the conversation. And I sort of put a slide of many representations of physicians, physicians in the white coat, physicians with a stethoscope around their shoulder, tired people, people using technology like scalpels on the phone. But also, I do think we have to admit that physicians, as I alluded to, have sought power. And I think more invidiously and a little less discussed as a downside, we care about prestige. People care about the prestige of the medical school they get into or the residency and how many papers did they publish and did they get an R01 and all these things. These are important achievements. I'm proud of the work that I've done. We should be proud of the work that we do. But we fetishize this more than we fetishize being an outstanding listener or that person that we would send our family to. The people who get in front of us in ground rounds are often really excellent academicians and they deserve praise. And also, we need to make sure that we are putting front and center the really most important things that we value, which is best care at the bedside, which is a bit more intangible, but we need to value that. And I think we need to rid ourselves of the sickness of trying to be a sneetch with a star on our belly. At a systems level, I also think we have a sickness that we are uniquely positioned to root out. I think we all know that the business of healthcare is gravely broken, and the system is increasingly disadvantaging many populations and restricting our ability to provide the best care or to receive the best care. This is a really lovely editorial by Adam Gaffney and colleagues. They're citing the many examples of what is wrong with our business model. Here is one looking at in the pink line, the growth of physicians over time versus the growth of healthcare managers. The administrative superstructure of medicine has just blossomed in the last decades. And partly, there are good reasons for this, but partly our administrative costs have just ballooned. And I think you will agree that there are many pharmacy benefit managers and other insurance conglomerates that are making huge amounts of money on a system that they largely parasitize. We need to get rid of this. This is not working for our patients. Having our doctors and nurses and other caregivers sitting in front of laptops while the profits and insurance companies grow is not a good thing for our patients or for us. And doctors can't just kind of fix that problem. They're not totally in control of the system, but doctors and nurses and other healthcare workers can be powerful advocates for change. Some of us do this, but to be honest, we also get paid well and like our jobs and may not have reasons to burn it all, may have reasons not to burn it all down, but we kind of need to burn it all down. So that transitions to Speak Up. So this is Dr. Reed Turkson. He's an internist formerly of Drew Medical College, the AMA, double M.M.Sc. Most recently, he's the co-founder of the Coalition for Trust in Health and Science. And he says, the modern interpretation of the Hippocratic Oath, to me at least, he said, is that we have a responsibility to the vulnerable person to translate a lifetime of expertise into service and to discourse with society. We have to build our skills in engagement, in trustworthiness, in countering misinformation through medical school training, our residency experiences, and our continuing medical education. I was never trained in how to counter misinformation. I got some approximate training in how to be trustworthy, but I think we could focus on this stuff more. And I would say that the more AI becomes smarter than us, the more this is our core work. And we have lots of great examples of people who have spoken up, but done it effectively in physician roles. So Dr. Megan Ranney She was a ethics grand round speaker here a few years ago. She's a really powerful advocate for gun control, researcher in this space, who is incredibly skillful at sort of saying, I understand why people have guns. I understand why it is frightening when you hear a government say that they're going to take away your ability to protect themselves. I don't want to do that. What I want to do is protect you from suicide at home. I want to protect you from your children getting shot. And we can come together, as most Americans know, and come up with solutions that aren't maybe what the NRA wants, but are what most of us want to have. She's an incredibly calm, supportive, non-judgmental, effective speaker. Dr. Mona Hanna has advocated for safe water in Flint. She's a pediatrician who was called to help because her patients were dying of a public health catastrophe. She spoke up with numbers and with diligence until people paid attention, and she had a unique platform because she was a pediatrician. Dr. Joya Mukherjee is the Chief Medical Officer for Partners in Health, the organization that Paul Farmer and others founded, spreading healthcare across the world and advocating for health equity in ways that people did not think was possible in the global health sphere. She's an infectious diseases doctor, also an activist, very powerful, speaking to the call to arms to do better with data, with expertise. And then Dr. Jim O'Connell. He's a hero of mine. He is an internist who, when he graduated from residency at MGH, was on to a prestigious fellowship he thought in endocrinology. And the chair of medicine at MGH said, I have a different plan for you. I need somebody to come and run this homeless shelter for a couple of years. And then after that, as the chair of medicine at MGH, I'll get you any fellowship you want. So 50 years later, 40, 50 years later, Jim is still working at Boston Healthcare for the Homeless. And he has incredibly powerful stories of working face-to-face, humbly with patients in a way that makes difference in their lives. So he and his team have sort of built Boston Healthcare for Homeless to be a national model. He talks about one of his first patients in that setting wouldn't even look at him, wouldn't even talk to him. And he had sort of a horrible condition in his feet that Jim wanted to try to help and treat with antibiotics. Guy wouldn't even interact with him, wouldn't take his medicine. And the nurse said, just sit down and clean his feet. Don't talk to him about medicine. Don't try to give him prescriptions. Just clean his feet. And he did that day after day after day. And ultimately, after having been a true healer to this guy, then he could treat his feet. And he has an incredible book called Stories from the Shadows, where he talks about the many stories of earning trust with this very mistrustful population and really making a difference built on that foundation. Incredible guy. When we speak up, we're speaking to this guy. This is who I picture. So a story for you also from the pandemic. I was on the radio, same radio station, sort of conservative-leaning talk radio station in which I was corrected about the risks of COVID vaccines. And almost every time I was on this talk radio show, people would call in with great questions, but almost every time a familiar voice would say, Dr. Lahey, how much have you been paid to misinform the Vermont public? Or, with very mistrustful voice. And having experienced a pay cut during COVID, I was a little triggered by that question. But I realized that if I responded with acrimony, with a holier than thou attitude, with kind of appeals to my great expertise, and let me tell you about my resume, I would alienate not just that guy who probably I couldn't win over, but everybody else was listening. So I tried really hard to picture this guy. He's just making breakfast. He's just trying to get his French press to go down a little bit faster. His stomach is rumbling. He's kind of listening with half an ear to this radio station or this podcast or whatever, mostly thinking about his day. And what he's going to remember is not the facts that I say or the misinformation that somebody else says, but how we made him feel. Did we comport ourselves as somebody who he would trust? Were we reasoned? Were we thoughtful? Did we express understanding of the concerns that they had? Did we seem to like a reasonable person that he could come in and ask advice of? Or were we angry? Were we polarized? Were we the kind of person he was like, switch the station? Tried really hard to remember this guy when I was thinking. I also, whenever I'm having that feeling in the exam room that Dr. Kapila talked about of the wall going up. I think about this guy inside that person, but afraid, and how can I reach him again? My former colleague at Dartmouth, Brendan Nyhan, who made his name researching vaccine messaging and trying to correct vaccine misinformation. And he found, somewhat concerningly, that if you come to people who have some mistrust in vaccines and you just share the facts of vaccines really do work, sometimes you can get what they call the backfire effect, which is sometimes that can worsen mistrust, just the facts can. And he says, don't take it too far. This occurs, but also you can show that rebutting misinformation can work. But he said, very importantly, that much more powerful in any study than relaying facts is if good information is relayed by trusted intermediaries, the kind of people that lets the person's force shields go down and they'll let the information in and believe it. Well, trusted intermediaries, that is us. Your healthcare workers may not always be your trusted intermediaries, but those incredibly trusted nurses, incredibly trusted physicians, case managers, I would say school teachers are also part of the healthcare workforce. We are trusted intermediaries, and so we can break through. Which brings me to James Baldwin. It was one of my favorite quotes from him, but I want to flip it upside down. So he said that we can disagree and still love each other unless your disagreement is rooted in my oppression and denial of my humanity and right to exist. And we often cite this quote to sort of say that some disagreements I'm not going to engage in. In that case, you really can talk to the hand if you can't give me basic respect. And I think that's a valid use of this quote. But I also think you can flip it and say, who can you disagree with? Who can you have conversations with people about challenging political content? People who care about your humanity, us. If you truly get up in the morning to heal people, to make them suffer less, to make them live longer, to try your best to just be honest with people and bring the full might of 2026 medicine to their service, you deserve to be heard, and I think people can see it and tell the difference. And so I think the sense of we could never make a difference in this is just wrong. I think we're exactly positioned to make a difference. Curiosity, I said, listen with curiosity. I love this recent publication in Nature Scientific Reports in which they were looking at kind of political polarization and how to instill curiosity, because they were sort of saying if we're all just polarized in our camps and can't even really find the middle or talk to each other, we're lost. The current stasis will continue, that fascism rises when we don't have communities. They did a really interesting study where they sort of assessed our perceptions of our own open-mindedness and our perceptions of our political group's open-mindedness. And it turns out that we will behave in a more open-minded fashion if we believe that our in-group is open-minded. And you can even affect this. So if we tell stories of times when we were confronted with a new piece of information, myocarditis cases that I didn't know about, and we took it in and were open-minded about it, that not only shows us that we are open-minded, but it can influence other people to be more open-minded. So our open-mindedness is a malleable thing, and we can do interventions to improve it. We can, for instance, talk to people about political polarization and examples of our trusted colleagues who have been flexible, shown some forms of acceptable compromise, and use that to build a better dialogue. Uncertainty is the other thing I think we need to express, and I think this is a natural reaction. What do you mean uncertainty? I'm trying my very best. I was just teaching in convergence to the medical students, and they're trying to present clearly and not look stupid on rounds. And so we were talking about, how do you do that? What's the game? What's the secret language of doing this? So if we're trying so hard to get the right answer, to do good for our patients and not look like dorks, why would we possibly want to indicate uncertainty? So this is a really interesting study where they took 4,000-something survey takers, and they portrayed a fictional foodborne outbreak, and then sort of played off of it these different communication strategies. Some were just factual, some were factual tied with uncertainty, some were factual tied with uncertainty with, and we promise we'll do the right thing. And they found that those messages that did admit to uncertainty were more persuasive than those that just said the facts. Also, they said that if you expressed uncertainty and then said, but we're going to get to the bottom of this, we are working day and night to get you the answer, we are going to discover a medicine for this, we're going to figure out who really needs this, then that was the most trusted information. So if you want to look it up, there's the recent reference. Okay, so listen with curiosity, express uncertainty, remember that guy making breakfast, speak as a physician from your expertise, but not from on high, and then belong to the community. So Dr. Quinn Capers, who gave this talk in 2023, reminded us that Black patients are much more likely to trust Black physicians and to experience better healthcare outcomes when their physician is Black. That racial concordance is associated with better healthcare outcomes. Complicated inputs into that, probably related to trust and also related to bias on the part of the clinician, and also why is it that there might be a diverse healthcare workforce and how might that be part of a bigger superstructure of trust and high quality outcomes. But I think a really important clarion call that we need to diversify the healthcare workforce even more. We have done much better than in yesteryear at gender balance in healthcare, although not at the most well-paid professorial ranks. But racial representation in healthcare is lagging far behind. The benefits of diversity go beyond just improving the chance that that patient and physician have some similarity between them, that patients can see themselves in the community of healthcare. There are now a few studies looking at healthcare outcomes in patients cared for by male or female physicians, and the pattern is pretty clear that outcomes are better if you're cared for by a female physician. So I think having, sometimes when we talk about diversifying the healthcare workforce, there will be an instinctive rebuttal that sort of says, hey, but we're only here about quality. We got to make sure we get the people with the really awesome board scores in, and we're sacrificing quality by being diverse. This is not true. It may be true that getting a certain board score helps you maintain your homogeneity of people who could achieve that good board score because they took a test that was really well suited to people who look just like the people who got good board scores. But if you want the best quality care, you get the best people in the room, partly by encouraging the best people to be in the room by not using metrics that are designed not for them. So diversifying the healthcare workforce and making sure that it is good diversity and diversity with excellence is the way to go. And I think we'll see this pattern go across other demographics as well. I got to spend a few days in Boston with Dr. Herman Taylor, a cardiologist, who, when he was giving this talk a few years ago, talked about the mothers of the church in Southern churches, that these trusted older women who sat in the front row and would get people to change their diet and would sort of run the vaccination drive and were the trusted elders in the community. This, to me, connects to belonging in the community, partly because we have to belong to the community like they belong to the community, not off in an ivory tower, but in the trenches, working side by side with the people who we're working with respect as equals to get there like they were. We need to be like them. And if you're looking for partners, those mothers of the church and the people like them in our communities, those are our natural partners. So I'll close with talk the talk and walk the walk. So on his first day here, Dean Page talked about how professionalism is central to everything we do. And I think you'll agree that the look and feel of the institution has changed. We had a public deliberation about our professionalism statement. Natalie Feldman and Liz Hunt have put forward the accolades with the dean's support. We have awards in Professionalism Week. Signs are up. We are talking the talk. But that's not enough. We need to do more than that. Dean Page also talked about how this is not an easy time to have a talk like this. This is not an easy time to have a renamed but still functioning DEI office here or at the hospital. This is not a time to focus on supporting diversity in our student body, and yet leaders do. We do. We can double down and keep focusing on this work, even if we think we might get an uncomfortable call from the federal government, even if there is some risk of loss of funding. Should we change the names to useful synonyms in our grant so that the likelihood of some intellectual terrorist coming in and stopping our grants is lower? Totally, but should we keep on doing the work? Absolutely. I think the community depends on us to exhibit courage in this place. There are lots of examples of this. If a major leader in an institution is behaving inappropriately and it continues on for years after year and it is not addressed, people know it and people know that that affects the accountability culture and they won't really believe the talk. But if a major leader has an employment change as a result of their misbehavior, that sends a strong, good signal. And I think we can all think about at the dean's level and at all of our levels, are there professionalism lapses that we're uncomfortable to address, but we could do a good, gentle, but firm way of correcting the community in a way that has a profound effect on the silent people around us? I think there are many opportunities for us to do that. So in conclusion, from tattered hierarchies to our misbehaviors to others' misbehaviors, trust is injured. And there is a call to make a difference because it can hurt people if they're not getting the vaccines from us, not coming into care, not getting the best possible care. And I believe there is this algorithm that largely has to do with doing the stuff that we knew we were supposed to be doing in the first place, being the good listeners, being the advocates, speaking up about the things that we are expert in, but we have to be really careful of some of the pitfalls that we've had, the ego, the money. And we have to get new skills in combating misinformation and being trustworthy across differences that maybe weren't there 5 decades ago. And so I'll close with this favorite quote of mine by the activist Howard Thurman, who says, "Don't ask what the world needs, ask what makes you come alive and go do it, because what the world needs is people who have come alive." I believe that this algorithm that I've described is actually really satisfying work. Being privileged to hear the story of somebody who's different from you in their time of greatest need and being trusted to be able to make a difference, to alleviate their suffering, to make them live longer, to just explain something that's difficult is an incredible joy and privilege. I love those days in clinic. And we can double down on that. Let AI do some of the minutia, do some public advocacy for a change in the system, get better at speaking in public, not in an inflammatory, polarized, negative way, but in a calm, trustworthy, community-building way. I think that we can have happier jobs and more fulfillment in the medicine of the future at the same time that consequently we improve trust. So I'll close there, and thank you for coming, and I love to hear your ideas too. I did want to call your attention to the post-lecture guide that Tiffany Delaney and Olive Gallmeyer put together. This is a QR code that goes to it. It has references to different articles and questions about this that I hope you'll find really useful. What did I get wrong? Yeah. Can you, oh, thanks, Helen. Do you want to pass it back to Toshi?
Tim, thank you so much. That was just a fantastic talk, so inspiring. And I could not agree with you more that the algorithm for earning trust, it is also sustaining for us and really is what brings meaning to our work. I wanted to go back to that slide where you showed there were the kind of things that we can't change and then the things we can change that are about communication.
Yeah.
And, you know, a lot of our communication patterns and habits and are, you know, deeply ingrained way before we get to medical school. What are some of the ways that we can move from some of these communication patterns on the right and move them over to the left?
That's such a great idea. That's such a great question. You know, partly, I think, I mean, we are all the products of our upbringing and our environment long before we get to medicine. And it's probably not realistic to expect us to leave that behind. I wouldn't really necessarily want that. I was meeting with the students today over lunch, and when they were talking about what can instill trust, authenticity was one of the things they really brought up. And so how can I communicate with my patient in a way that really shows up as me and I'm not just stiffly faking it, but yet it does kind of, as you're saying, sort of takes the rough edges off. Partly, the easy answer is that medical education is a great context for communications training and giving people really serious feedback on how they're performing in difficult conversations, like somebody who's resistant to vaccines, I think is a way to get there. For me right now, thinking about professional identity formation is everything. And I also think a lot about our own sort of self-talk about what it means to be a physician. I have a lot of ego engagement and doing a good job. So important for me to know how to take care of my patients and to have the right knowledge and all that stuff. It can be really kind of confronting to your self-image to realize that, wow, the way I communicate is counterproductive in this way. And I'm thinking about my wife again for this one where, you're a great communicator, I'm a great communicator, we love each other. But when we were first married, we had to hammer out how to actually live together without killing each other, right? Many married couples do this. And having the humility to be able to figure out what it is that's just not working and kind of get over it, it requires you to be open to the possibility that that's not about you being a bad person because I'm quick to criticize it for like, what don't you get about the benefits of vaccine? I have all these clinical trials. I needed to unlearn that behavior as best I possibly could. And I think I was less likely to do it if I sort of thought that was an ego affront and more just like, I am a tool and I am here just to be used just like a scalpel to achieve the best outcome. And that approach I had was not achieving the best outcome. So sharpen me so I can achieve a better outcome. And the more we can kind of frame our professionalism like that, I think the better. I also wonder about just our diversity. You know what I mean? Like the more we are able to give each other feedback about those jagged edges of us, the more we are capable of communicating across different divides, the better we're going to be with whoever is in front of us. Yeah, other thoughts? Yeah.
Same topic. Well, I was having her in a family member.
Oh yeah, mic on the way. Thanks.
Hi, it was really great. So many things that I'm thinking about. I could have like 10 questions. If you've been in any of our faculty meetings, you would say that was normal for me. But thinking about in primary care and family medicine and communication, I'm like of the school, like I tell my patients all the time, I remember when there wasn't a computer in the exam room.
Yeah.
And we actually just looked at each other. Now we have AI, we look at each other again.
Yeah.
And I always called my patients with everything.
Yeah.
And that was appreciated and that was the expectation. And it's not possible now. And even like how we communicate now with the MyChart, I think is brilliant.
Mm-hmm.
But it's it's much less personal.
Yeah.
And the expectations are often not met between like what the providers think should be use of the tool and what patients expect from the tool. Like,
yeah.
The expectation. And I think that in some ways it's really great that it has filled a necessary gap, the way we communicate through triage nurses and through the technology of like MyChart, but it also, it creates an impersonal relationship that I think it has somewhat eroded. And
yeah,
I don't know what the answer is, but I do notice that it's a big difference in our practice of medicine from where we were.
Yeah, it's sort of like the platform, sort of the organizational and financial platform on which these individual dyads of patient and clinicians are interacting is just eroding underneath them. And I'm gonna stand here and I'm gonna have this conversation despite that restriction on my ability just to be a good doctor. And we're doing our best to compensate for these things, but it's not sustainable, I don't think. So in the middle of this broken system, of course, as you know well, there are things we can do to mitigate that downside. So yes, our appointments are incredibly tight. And also another topic of conversation with the students today, when I see the physician, thank God so far, I want to get in and I want to get out. I really don't want a long conversation. I just want my vaccine, I want a blood pressure check, and I want a refill, and I got to go. So they can spend less time on me so they can spend more time on the person who has a new cancer diagnosis. So we all use this in our clinics, kind of telescope in and out who really needs the care. And developing skills in that it's a real challenge, and you kind of can't do it until you get into high volume care, but sensitizing our students to that important skill is part of it. But you can only dance so fast. And I do think that the documentation requirements and some of the financial incentives that physician practices exist in, particularly primary care, are sick, and they are preventing us from doing the work that we want to do. I imagine, as you're alluding to, what would it be like if AI was really good at doing all of the documentation and all of the building, and so literally we were having the conversation and then doing the prescriptions or doing the procedures or whatever it is that we did, and that's it. How much more time would we have to talk? Also, we are under pretty serious financial structures to see a lot of people really quickly. And primary care, psychiatry, hugely underfunded and having a hard time recruiting people. And there's money behind that. There's a great reason for this. We have an unjust reimbursement system. And I think it's getting more and more unjust. And it's going to fall apart. And so I think we need to start advocating loud for the better system that sort of gets you in a room with the person for as long as you need. And you can't make that happen today, but we, I think, can help make it happen. I think we need to be, Becca Bell and people like her are incredibly good advocates. I saw you walked in here somewhere. Incredibly good advocates for legislative change or for public awareness about this stuff. We need to take a page from her book and get good at that stuff, I think. Yeah.
Tim, great
Yeah,
lecture,
okay.
as always. Really incredible. I know most of your lens was kind of looking at how do we create trust or rebuild trust with our patient.
Yeah.
A few of us in the room just got off of a pretty devastating meeting, and I won't go into the details of what that meeting entailed.
Something to look forward to, huh?
Uh-huh. But as an ethicist, as a clinician, what do you say to our students, our learners, our faculty, our staff, our clinicians who may not trust the patient in this current environment due to pressures on the system, but also misinformation and difficulties and maybe different views? Because I think in this current landscape, we're going to start seeing more of that.
Yeah. To put some flesh on those bones, we had a nurse whose jaw was dislocated by a patient last year, I think it was, maybe the year before. We have had an epidemic of violence in our hospital. Sometimes it's the threat of personal danger without actual injury. Sometimes it's actual injury. We have people who are afraid to come into work. We also have people who are just verbally, disrespected on a regular basis, and that's more common than it used to be. We have clinician burnout that results from that. I would say our nurses bear the heaviest weight of that disrespect and that violence, but physicians experience it, lots of healthcare workers experience, and that's the environment that we have. The ED, I should point out, to your specialty, is a hotbed of that stuff, much more affected than other locations. Partly, I do think it harkens back a little bit to changing demographics. That and I would just say the recommendation, if people would just do it, of course I trusted them more. It was not an appropriate expectation, really. You know what I mean? Like, I needed to be, I'm not saying this, I have ever experienced this actually, but had I been that physician of yesteryear, it was not really a completely appropriate power structure to have the physician be daddy knows best. And so partly there's a piece of this that is okay, and we just have to learn to be better diplomats and persuaders. But I do think we are experiencing alienating behaviors that we have not earned. And some of our best leave because of it. Partly, I think that's a problem beyond our fixing. I do think that if Tony Fauci is demonized as the source of all that is bad in the pandemic, it's expected that people's local physicians and nurses are going to take the brunt of whoever was influenced by that message. That depolarizing civic dialogue in general is part of the fix to that, and not everybody in this room has a lot of control over that. We try some of the interventions to fix this. We put up signs saying we're expecting you to treat us with respect. I think you and others in this room have been part of interventions to try to enforce expectations of reasonably trustworthy behavior. Not to say that we expect people to act like us, to talk like us, to look like us, that we cut people slack and expect difference and enjoy it, but that when it goes too far, that we have to be willing to say, and you're done. I'll save your life if you're behaving like that, but otherwise you'll come back until you can treat my people with respect. I do think we're having to flex that muscle more and more, and we hate it because we're not here to say no. We want to say yes, but I think we have to do that more. I also think this is a battle. I think it's a battle for the soul of the country politically, and I think the healthcare subset of that is a battle. And I do think, much as I have lived a comfortable life, we have to get used to that risk that maybe wasn't so present or so visible before. I'll give my version of this is that I will never forget the day that I was in a COVID patient's room, mask up, gown on, hot as hell, team around me wearing yellow, talking with this delightful Quebecois woman about her COVID, and she's breathing hard in between her sentences. And my phone keeps on jangling in the hot room, and I get a lot of pages, but this was more than that. So I'm like, you keep talking, I'll be right back. And I pull it, and this is my wife calling me over and over again, and I'm like, holy crap, who's sick? What's going on? So she was standing on a corner in Shelburne, crying. We're criers. Because there was a sign on a telephone pole that said, Dr. Tim Lahey, paid liar. And somebody was influenced by vaccine messaging to put this up for me. And this was in the hot days of the pandemic. And many of us, I don't know if you did, but many of us experienced this sort of blowback. The feds came in and captured somebody who was making very threatening remarks on Facebook about public people in the vaccine sphere in Vermont. I did not get into medicine to experience that. And I had to think long and hard about whether I wanted to get on the radio again or otherwise sort of advocate publicly. But I do feel like I need to be courageous to do it. And I think we have to be willing to take the risks. I think we have to be the helpers, the Alex Preddies who help the woman on the street, even if they will be murdered. I think we have to be those people. Yeah.
Good evening. Thank you so much for coming to speak with us. There was a quote you had on your presentation from Dr. Rudolph Virchow. If medicine is to fulfill her great task, then she must enter the political and social life. And you just mentioned about courage.
Yeah.
And some of the stories that you share in reference to having your name on the signpost, having us as providers now being seen as the perpetrators or being negatively perceived, this sentiment is something that some physicians of colors have just experienced throughout their entire career.
Yeah.
So this is not new.
That's right.
For physicians of color or women or any other category in medicine. And a quote by Dr. Reverend Martin Luther King comes to mind. We may have all come on different ships, but we're in the same boat now. So with that in mind, and you highlighting the politicization of health, which then leads to the politicization of safety, again, around that people of color in America, like you mentioned Alex Peretti, there's been violence to people of color since the beginning of America.
Yeah.
Again, we're all in the same boat now.
Yeah.
What way do you think we haven't done before that will make a difference now?
I like how you have a gentle wind up into the hammer of a question. I don't know the answer to that, and I'd love to hear some of your thoughts about what our response is. I think things that come to mind for me do relate to cowardice. That if I'm comfortable in my life and I am intellectually aware that there are people who look different from me or live in a different zip code or whatever the source of difference is, who are experiencing different outcomes, and I sit in my comfortable home and I allow that to be the case, it's completely understandable. We all want safety, but that is cowardly. And I have been cowardly, and I need to rid myself of that behavior. And so partly just naming this, and to say that, connecting this to prestige, we have really come to fetishize that you went to a great institution, you had a great GPA, you rocked it on the boards, whatever form of prestige we have in medicine. What would it be like if we really trumpeted courage? It would be a different value set. And I think the beginning of that is talking about this. Collective action, I think, is the other thing that comes to mind, is I am afraid when I am alone. But I think as we are seeing, we are not alone. And powerful collective action can happen and can reverse injustice. And it doesn't flip the switch and make it all better, but it is better than sitting by and letting it happen. And I don't expect myself to be historically courageous. But if I can just be slightly less cowardly and stand on some street corners with some signs, if I can think about what I want for my daughter, for my son, for people I love, and how that same love could go to people who have whatever difference it is from me, and fight for that in some way, it would be better. We would still be, many versions of broken, but at least if we were feeling like we were a band of brothers and sisters fighting that great fight, I don't know. I think that would also be the cure to burnout. That's a beginning. I don't know. What else? No, honestly, I'm asking, like, do you? Yeah. Oh, you thought it was all me answering the questions?
It's your talk.
Yeah.
No, absolutely. I think getting into what you, with the dear Congressman John Lewis mentioned, good trouble.
Yeah.
Right? Collectively, we have a way larger voice than we would individually, and having these conversations is of absolute importance.
Yeah.
I think for someone like myself, who I see, the physicians past that you present, a lot of them physicians of color.
Mm-hmm.
And it does sadden me to understand that we are no further today than we were at the civil rights movement 400 years. Like, we're not, and to then identify that there are overt intention in not diversifying the health landscape,
Sure.
not encouraging students of color to advance. Like, we are changing names. I mean, so much. I don't even have to go into it. We all are aware. But to continue to stand in the space as we are now and continue to have these conversations and engage in this work, call it what you may, is of great importance. And I thank you for coming to have this Martin Luther King lecture, identifying as you are a Tim Lahey, right?
Hey, Tim Lahey.
A Tim Lahey. So I'm thankful that we have this opportunity to have these conversations, because you don't know what you don't know. And once we all come together, when we know better, hopefully we'll do better. That's really all I have to say.
Amen. Well said. Maybe I can yes and you. I think we are better. We are having this dialogue in public. We do have leaders who are making a difference. We are seeing collective action that pushes back. We have more rights, but we are also seeing a powerful reaction to those successes, trying to completely reverse them. Very powerful reaction. And just as John Lewis had to cross a bridge and risk his own life to get there, I think those moments are coming for us too.
We're all now experiencing what may have been previously targeted. We're now all experiencing.
Oh, yeah, sorry, thanks.
I forget, thought him and I was having a conversation. I actually took note of a quote by James Baldwin when you spoke. It said, people who treat others, um, people who treat others as less than human must not be surprised if the bread they cast out onto the waters comes floating back to them poisoned. I get emotional a bit when I think about this because you previously thought you were hurting one demographic, but
Mm.
now we're all hurting.
Yeah.
What do we do when we're all in a sinking ship, right?
Yeah.
So forgive me, it just, when I think about the current activity that we're having on the streets and what we're doing, and we're sitting here having a conversation, you wonder, what what can I do? What should I say?
Yeah.
Where should I go? So I'm just happy we're having these conversations at all, and we
Yeah.
have the space to do so.
Thank you for showing your heart.
With that, what an amazing evening. Tim, thank you for an incredible talk, and even better than the talk, perhaps, providing a space for this conversation.
Yeah.
Really, really moving and important. So let's give Dr. Tim Lahey another round of applause.
Thank you.
Well, before we close, I need to give one just number of thank yous to medical communications. Stephanie Kniffik hates the fact that she's not here, but not going to go into detail, but it's better that she's at home and maybe she's watching online. Stephanie, take care of yourself. Our ComAV, Bruce and Jason, who universally provide a flawless event. So let's give those people a round of applause. And I don't normally do this, but to Dave, our photographer, who's always here and never leaves. Dave, thank you. And no matter what you call it, it's doing the work. And that's our Office of, it's Intercultural Excellence now. Tiffany Delaney, Olive, and Noah, thank you so much for being here and everything you're doing. And just in closing, I want to, as much as anything, thank the people in the room for being part of this, and those of you on Zoom. The only thing better than being on Zoom would have been to be in this room with us, but we're really grateful that you were able to join us. Tim, you said it's a battle, and I can't sugarcoat that, it is. As we go into battle, I can't imagine being surrounded by better people in a better place to do the best we can in this circumstance. So with that, I wish you all well. Thank you for being here tonight and for just an amazing evening. Thank you.